Thank you very much, Wojciech. Good afternoon for those of you that I haven't met. My name is David Huang. It's been a pleasure meeting several of the people here. That's probably the biggest advantage, biggest benefit here is for us to get to know the personal side of the story here and also get to learn from each other on this long QT syndrome, this genetic condition. We've learned a lot from your history and from your experiences, frankly. I know this is a fairly sophisticated crowd, so you probably know a lot of what I'm gonna say, but I'm gonna go through these just in case some of you may not be as familiar with these devices. And hopefully we will have some time to have some questions and answers. I hope you can see this well enough. So ICDs, or implantable cardioverter defibrillators, you've heard this term already throughout the talks today, but basically what it is, an ICD is a protective device where you see many times in TV news shows or TV hospital drama shows where the physicians or nurses shock a patient's chest to revive them, to rescue them from cardiac arrest. So those paddles, the machine, that defibrillator, that whole thing, that whole unit is now miniaturized into a device called ICD, where it can be implanted into someone's chest. So an ICD is useful for preventing sudden death in those people who may have known life-threatening ventricular arrhythmias. And it is effective in protecting and preventing cardiac arrest in these high-risk people. So people who have had cardiac arrest certainly are candidates for ICDs. People who are at high risk for cardiac arrest will also be candidates for ICDs. And these days, ICDs often have pacing backup, pacing function. That is, it can also treat slow heart rhythm issues. So if the heart rates go too slow, the ICD will have a pacemaker that will serve as a backup pacemaker as well. And specifically, there are some patients who have long QT that may also have accompanying bradycardia or slow heart rates. So in those particular people, ICD with pacemaker backup will be a very appropriate device choice. So the ICD is a battery-powered device with capacitors. So these capacitors will hold charges. So once the ICD detects an irregular rhythm, and if it decides that this irregular rhythm is a potentially life-threatening irregular rhythm, the ICD will charge up. These capacitors will hold a charge, and once it reaches that charge and the person continues to be in a life-threatening arrhythmia, those charges would be then delivered through the ICD and through the wire that's connected to the ICD. And this can be effective in stopping and terminating the life-threatening irregular rhythm. And that's basically how this ICD works. So when do people need an ICD? Usually are people who have had these life-threatening ventricular arrhythmias, like we said, and people who have survived a sudden cardiac arrest. Most of the ICDs that we put in clinical practices in hospitals are usually in people who have prior heart attacks, usually in people who have a weakened heart muscle or so-called cardiomyopathy. Long QT syndrome, certainly one of the reasons, but to be honest, is actually one of the less encountered reasons why we put in an ICD. There are other conditions genetically related, such as Brugada syndrome, or people who have congenital heart disease that may need an ICD because they could be at risk for dangerous heart rhythm problems as well. ICDs are usually implanted through the vein up in the chest. We can get access to the vein under the collarbone there, or the clavicle. Once we can get access into the vein, that vein is connected directly to the right side of the heart. upper chamber and then lower chamber of the heart. And these wires will then be connected to the defibrillator. The defibrillator is about the size of a pocket pager, if you know what I mean by that. And then that whole system is then fitted into a pocket, either under the skin or under the muscle. And then everything is sewn up and contained inside the system. Dr. Rosero had mentioned, alternatively, there is a system, a subcutaneous ICD system that's become available over the past few years. That system has the advantage of not having anything inside the heart or inside the blood vessel. So it has inherent advantages because if there is a break in the lead is can be changed without as much risk. However, these subcutaneous systems do not have a backup pacemaker as yet at this time. We went through this a little bit already. There are two ways how an ICD can work. One is once it detects the irregular rhythm and it decides that it is a life-threatening irregular rhythm, it can give the heart a shock through the battery and the capacitors. Another way that the ICD can work is that it actually can deliver mini impulses, mini discharges that can speed up the heart rate. So if people have a faster heart rhythm that's more organized, that what we call ATP, or that overdrive pacing, can stop the irregular rhythm. Most long QT patients, though, however, do not have that type of irregular rhythm. They tend to have a more disorganized, fast heart rhythm. So if they need therapy from ICD, it often is in the form of a shock. ICDs now also have very good storage memory. So these devices will record any potential irregular rhythms, either short ones or long ones, and it will always record episodes of fast heart rhythm that require an ICD therapy. So the provider, your nurses, your physicians, can retrieve these information and be able to decide, oh yes, that was an appropriate rhythm that required the ICD therapy, or vice versa. And then we'll switch gear really quick about AED, this automatic external defibrillator. You've all seen it in the airports, airplanes, government buildings, or even in schools. Automatic defibrillators are now very commonplace. It has become a lifesaver for many of our patients that have not been diagnosed before, and because they survived the cardiac arrest through AED, and then they come to us for evaluation, and then we eventually diagnose either long QT or other conditions that lead to these cardiac arrests. AED works in the same way that a manual defibrillator will work in the hospital. Instead of the paddles, these AEDs use stick-on patches that a bystander or rescuer will put on the chest. And these AEDs often will have verbal prompts. So once these stickers get put on the chest, it will analyze the rhythm, and if the rhythm is what they call a shockable rhythm, usually meaning ventricular fast rhythm, ventricular fibrillation, the AED will prompt the bystander or the rescuer to push the button to deliver the shock. And some of these AEDs actually also have automatic shocks now once it detects these life-threatening rhythms, and then the audible part will be to tell the people to clear and not touch the victim. So who can use an AED? It is meant more for non-medical personnels, first responders, police, fire rescue, sometimes even flight attendants and security guards. It can become a prescribed device for some of the families, especially if they have young patients, young members in the family that have been diagnosed with potentially life-threatening conditions such as long QT. Dr. Vanoker mentioned this a little bit, And the local American Heart Association branches will have official trainings for AED. So you can look that up. I believe I have this heart.org CPR. If you are interested, that will be the website to go to. And you go there, and then you type in your zip code, and then they'll be able to locate the local branch of the AHA office, and they can provide with formal AED training. So this is my backup slide. I guess we have a little bit of time maybe. So there are official recommendations about when an ICD should be placed in people who are affected by long QT. So, and Dr. Zariba went through these class 1, class 2 recommendations. So class 1 are recommendations that should be followed. So if people meet the criteria, they should have an ICD. So under class 1 indication, ICD should be used with the use of beta blockers in patients who have had a previous cardiac arrest. That's a class 1 recommendation. So for, I believe some of you fit that criteria here in the audience. Class 2, meaning that there is good evidence, but not absolute, not free from other opinions. Class 2A, there's good indication, consider ICD implant in addition to beta blocker in people who have passed out or people who have demonstrated life-threatening ventricular arrhythmias while on good doses of beta blocker. That's a class 2A recommendation. Class 2B recommendation, so less people, less of the experts agree on this. Not quite as many agree with the class 2A or class 1, but many will recommend consider ICD in addition to beta blocker in asymptomatic carriers for long QT2 or long QT3 where the QTC is greater than 500 milliseconds. So that's a class 2B recommendations. These are from the latest guidelines. So this is what we call an expert consensus. So these are all the experts, people who take care of patients with long QT. They get together and they say, these are the conditions where we should consider these particular therapies. And this is from the 2015 update.